This video has been funded by an educational grant from Fresenius Kabi, Swiss BioSim GmbH.
If you were to say which is the highest risk group, those are individuals who have already had a fracture. Because if you've had one fracture, you are at very high risk of another one.
The loss of bone mass, density and strength plays a large part in the reduced quality of life for many elderly people and can begin earlier than expected. Professor Elaine Dennison from the University of Southampton speaks with us in this special series to discuss the clinical presentation of osteoporosis, the treatment landscape, and risks associated with treatment types, including no treatment at all.
Osteoporosis is a very, very common condition. We typically see it as people get a little bit older, but we do see it in young people as well. And it's important because it's linked to bone fractures. So osteoporosis does mean quite literally porous bone. Obviously, we have ways of diagnosing it, but it's important because it is a very important risk factor for a bone fracture. And it's the bone fractures, of course, that people notice and are painful and have a big impact on personal and societal costs. In terms of risk factors, so we know that some people are particularly vulnerable. So I've already said it's more common as you get older. So we often see older adults who have got osteoporosis, some of whom will have had a fracture already, and some of whom have been picked up through a DEXA test that's been performed for some reason. It's more common in women than men. It's linked to certain medical conditions or treatments that someone might have had. So if someone has needed big doses of steroids, for example, that greatly increases their risk of osteoporosis. And we know that some lifestyle factors are important. So if someone has been a heavy smoker or has had a history of heavy alcohol intake, someone who has got some GI problems, so there's a problem with malabsorption, all those things can impact their risk. And those are the people in whom we'd particularly consider the possibility of osteoporosis. If you were to say which is the highest risk group, those are individuals who have already had a fracture. Because if you've had one fracture, you are at very high risk of another one. So that's why we have fracture liaison services that actually identify those people and try and sort of support pathways towards treatment. But if someone has got risk factors for osteoporosis, we would really want them to be picked up and identified and actually put on appropriate treatment, because no one wants to have a fracture. So it's far better to prevent all fractures than, to start when someone's already had one.
What kind of treatments are commonly available?
There are lots of things that play into a decision. So if you start with tablets, so if someone is going to be prescribed tablets, then most commonly it would be an oral bisphosphonate, and there are several of those drugs available. They're very effective. They're a very good treatment. They've been around a long time. We know a lot about them. The downside to them is that they have to be taken in a particular way. So they have to be taken on an empty stomach, sitting upright. Stay upright for half an hour after you've taken them. So that's quite a restriction on people's lives, and not everyone likes that. And if they've got a history of problems with indigestion, it's probably not the best fit for them. It also relies upon you remembering to take the medications. So some people are very good at remembering that weekly routine. Some people say, actually, that's going to be harder for me, but they are very good treatments. And they fall into the anti-resorptive group, so they stop bone being broken down. Moving on to some of the injectable treatments, well, there are treatments that you could have at your GP surgery. So these are things like denosumab. This is one of the injectable treatments that you can have. That's a 6-monthly injection that would normally be done at the surgery. People often get on with it very well, but there are considerations about what would happen when you want to come off that treatment. That's the real challenge with that, because unlike the oral bisphosphonates, where you have the option to start and stop, with denosumab, once you're established, there are risks associated with coming off the treatment. So you have to be mindful of that as someone starting on that treatment. So possibly it's more suitable for someone who's a little bit older, where you'd be happier thinking about long-term treatment. That is also an anti-resorptive treatment. Quite a lot of bone, undo all the good, and even have rebound spinal fractures. So usual practice now is to actually, if someone wants to come off denosumab, to follow up with celedronate injections, and you might have to give quite a few of those monitored with some blood tests called bone turnover markers to make sure that actually you've given enough of that drug for that. So that's normally the challenge with denosumab. Other than that, it's the usual side effect profile in terms of we worry about, or we always counsel people about, risk of osteonecrosis of the jaw and atypical femoral fractures for most of the osteoporosis treatments. If you think about some of the other treatments, so I've already spoken about oral bisphosphonates, you can also have an intravenous form of that drug. So we can give annual intravenous injections of bisphosphonates. That's great because you don't have the problems of the palaver of taking it in a particular way. The challenge with them is that you have to come up to the hospital once a year for the injection. Often you'd have like a course of 3 of those. But specifically what you would worry about is some people have quite a pronounced reaction to the first infusion, so it can make them feel quite fluey. Not everyone has that, but it is something that we recognise. So the patient has to be mindful of that. And obviously that's another anti-resorptive. Moving on to some of the anabolic treatments. So I've been talking about drugs that stop bone being broken down. We do have bone formation drugs as well. And these are also injections. So we have things like teriparatide, abaloparatide, and now we have romosozumab as well. So we have these different, really very powerful therapies, which are normally given on a much shorter duration. So this is typically a one-off course of either 1 year or 18 months or 2 years. And these are injections that would normally be given by the patient themselves at home, or possibly by a carer if that's harder for them. But these are the sort of the true bone forming agents that we have available. So lots of drugs, lots of choices. And it's a discussion really about what the patient wants and also their level of risk, because not everyone has access to every drug therapy.
How can treatment selection or sequencing be tailored?
We have fracture prediction algorithms, tools such as Frax, and others that will identify or try to estimate someone's 10-year risk of fracture. And for some people who are identified as being at very high risk, you would prefer probably to go for an anabolic, so a bone forming agent, than a drug that stops breakdown, because intuitively that's going to do more good to the skeleton. Now, there are inevitably restrictions in healthcare systems about how you can access them, but we are seeing better access to those anabolic agents. So if someone had a really low bone density, we'd certainly be thinking, well, actually, should we be going for an anabolic agent earlier? And even the order of the drugs that you give matters. So what would normally happen, and what has historically happened, is people would start with an anti-resorptive drug, something like a bisphosphonate, and then move on to an anabolic. But there's quite a lot of research now that says that actually giving an anabolic agent as early as possible, even possibly in a treatment naive patient, will do the most benefit. So there's a lot of thinking about, well, if we can access some of these drugs a little bit earlier, we might actually do much better for the patient and actually for the healthcare system as well, because it will prevent fractures and the burden on the system. So there are lots of individual factors that feed into it.
How can treatment adherence be facilitated by healthcare staff?
It's hard because obviously, these things sound terrible, and if you have one of those side effects, obviously that's very, very difficult, but balanced about the risk of those against the risk of those very rare side effects is the very real risk of having a fragility fracture if you do nothing. So, you know, people have to obviously have all the information, but doing nothing is not, you know, it's not safe either in a way. And it's a personal choice, obviously, for people to make with guidance from their clinician. You can have the best drug in the world, but it only works if you take it, if it's a tablet, or if you go for your injections, or the system works and you get your injections. So in terms of tablets or anything that's very dependent upon the patient, you know, it's really important that I think that the patient is part of the decision-making pathway, and they really feel that actually they've been, you know, fully informed and have made the right decision for them. I think, you know, as you get older, you really, really, really see the importance of that. So because compliance with any long-term medication is only about 30%, and osteoporosis is obviously a silent condition unless you fracture, you're asking someone to take a drug that actually, you know, could have side effects that they could feel, or could have risks that, you know, might be associated with long-term treatment. So I think they really have to feel that they've made the right decision for them. And that, you know, I think that is what I would say. So it's great that we have so many options, but I think it's why it's so hard to have a, you know, a general, this is what we do, because no two patients are the same, and people will come to very different decisions with exactly the same risk profile, actually.